everyone. I'm Chris Casper-Riggs, the Organizational Learning Specialist on IDEAL. As I've been saying, and if you had a chance, please introduce yourself in the chat. This is the panel discussion on what are RCCE, key principles and best practices during the COVID-19 pandemic. And just as a reminder, we will be doing simultaneous interpretation in French and Spanish. Please click on the interpretation icon or globe in the bottom of your Zoom window and select your preferred language. So the flow of today's panel will have about a 30-minute plenary discussion from our panelists, who I'll be introducing momentarily. And then we'll aim for about 10 minutes of questions at the end of the session. If you have questions, please feel free to drop them in the Q&A box that you'll see at the Zoom window, and we will work on addressing them. Please, at any time during the panel discussion, if there's something. Okay. So today's session will be exploring 3 key themes around RCCE. We'll start off by thinking through what is RCCE and why it is important in the food security and nutrition security programming space. Then we'll move on to sharing some best practices and lessons learned from country and a regional level perspective about RCCE during the COVID-19, especially related to future shocks. Then we'll also spend some time reflecting on experiences in implementing RCCE initiatives into ongoing food security and nutrition security programming. I see a couple more people have joined, so if you want to introduce yourself in the chat, that would be great. But now I'm going to move on to introducing panelists and our moderator. So first up, we have Renuka Bery, who is a global health professional and an inspirational team leader who manages for excellence. As a strategic and collaborative problem solver, she leverages project management, budgeting, supervision, and training competencies to design, implement, and measure effective USAID and donor-funded programs. She has a deep understanding of and hands-on experience in behavior change and community development in diverse global settings that drives her passion for addressing challenges that can help improve people's lives. Her recent technical health areas focus on maternal and child health, nutrition, family planning, and reproductive health, water, sanitation and hygiene, and infectious and neglected tropical diseases. Our next panelist, Nicole Grable, is supporting Mercy Corps' social and behavior change and RCCE programming efforts. As a part of the COVID-19 Technical Response Unit, she supports program teams in layering their COVID-19 infodemic and evidence-based behavior change approaches through their strong community engagement programs. She brings 20 years of hands-on experience working across the private, public, and global health sectors in the design and creation of community engagement and behavior change programs. She blends private sector experience in global brand marketing, management, and product sales with global best practices and human-centered design to national level behavior change or community-based market-informed strategies. Our third panelist, Charles Kakaire, is the Communication for Development Specialist at UNICEF Eastern and Southern Africa Regional Office based in Nairobi, Kenya. Charles supports 21 UNICEF country offices in their social and behavior change interventions for disease outbreak and other emergency SBC efforts for preparedness and response. He currently co-chairs the regional RCCE Technical Working Group for Eastern and Southern Africa. He previously worked for the Johns Hopkins University Bloomberg School of Public Health, Center for Communications Programs on various projects in Uganda, World Relief, Indonesia, and Sudan country offices, and has overseen institutionalization of SBC capacity strengthening in select universities in Africa. And finally, our moderator, Arianna S. She's a behavior change and community health advisor at Save the Children US. She has a multi-sectoral social and behavior change professional with particular experience in risk communication and community engagement, public health emergencies. She led the RCCE pillar of USAID's Zika virus response in Latin America and the Caribbean and works on COVID-19 RCCE globally. She holds a Master's of Science in Public Health, Health Promotion stream from the London School of Hygiene and Tropical Medicine, and a Master of Arts in Sociology from the University of Edinburgh. And I'll now hand it over to Arianna to go over a little bit of what is RCCE and why is it important.
Thank you, Chris. And hello, everyone. Good morning, good afternoon, and good evening. So To start us off, just setting the stage a bit, I'm going to talk about what RCCE is, why it's important, why we do it. So RCCE is very simply the terminology used to refer to social and behavior change work in public health emergency responses. So the function of RCCE is to provide timely, clear, accurate, and actionable information to communities in order to enable them to protect themselves and their loved ones in the face of the emergency. This type of communication should be done through two-way communication mechanisms that build trust between communities and ministries of health and other partners, such as NGOs. And communities really should be at the center of planning and implementing the response in partnership with a Ministry of Health and other stakeholders. So some of the features that perhaps distinguish RCCE from social and behavior change are the accelerated timelines that we work with due to the emergency nature of the pandemic or epidemic in question. The very strong need for national and even regional coordination mechanisms, working with evolving information as these are emerging infectious diseases, which we often don't know much about, and we learn as we go. And then having really communities as equal stakeholders in the response, which we have learned strongly from Ebola, is crucial to the success of any effort. And then the two-way communication and rumor tracking mechanisms that I mentioned. So why is RCCE important, crucial to public health emergencies? Well, at the onset of a public health emergency, behaviors really are the only tools we have to prevent and mitigate the spread of a disease, and certainly seen that with COVID. So RCCE really is vital for the uptake of essential public health and biomedical interventions, both to prevent and control the spread of disease, all the way from the prevention behaviors to, for example, vaccine uptake, which we are currently working with. It also ensures a more effective emergency response by being driven from bottom up from the community level, and also RCCE spans throughout the phases of an emergency response, from the onset all the way to the second order effects, such as, for example, the fallouts on food security. So to kick us off, we'll hear from Charles, who will share some insights into best practices and lessons learned from a regional level perspective about RCCE during the COVID-19 pandemic from his experience leading the Eastern and Southern Africa coordination pillar, RCCE coordination pillar. So with no further ado, Charles, over to you.
Thank you very much, Arianna, for that, and good morning, good afternoon, colleagues. So my name is Charles. I am at the regional office for Southern Africa in Nairobi, and I do coordinate I do co-chair the regional RCCE working group, which we started last year in the first week of March, just before we had the first COVID cases on the continent. This was pretty much building onto an earlier conversation that we had around the need to establish a regional coordination mechanism for social behavior change within an emergency context. Just to note that by the time we set this up, we had just held a review and stock take meeting where we're looking at the work that we had spent the last 2 years on with regards to Ebola preparedness in 5 East African countries that border the Democratic Republic of Congo, which had been battling a long and protracted Ebola outbreak. So we came together, as partners in the region, again, UNICEF and IFA and the International Federation of Red Cross as colleagues in this, trying to see how we bring together colleagues to prepare for, for the onset of the outbreak, and seeing how we would be able to, provide some kind of regional coordinated effort that would then link into the country coordination mechanisms. So we set this up at regional level, and with direct links into the countries. In terms of best practices, again, sort of if I could dive into that. I mean, coordination really is sort of Arianna did mention this, but coordination is really one of those things that sort of stands between a good response and a bad one. We know for a fact that during emergencies, whether it's public health or any other, there's always too many partners. We keep joking that emergencies create experts, could create overnight experts into in the different fields, and social behavior change, unfortunately, is one of those fields where everybody else becomes an expert within an emergency context. So if you do not have a mechanism that at least tries and brings together everybody else in that space to be able to identify who is doing what, in what areas, where do they have a comparative advantage over the others, and how can we leverage on each and everybody else's skill and competencies to be able to ensure that we provide concerted response. Of course, not losing out the fact that also, coordination helps to also make sure that there's harmonization in terms of messages, in terms of approaches, but also and to try and avoid duplication of the same activities within the same locations. The other aspect really links to also 2 pieces of work that 2 work streams that we have within the regional working mechanism. One being a community feedback, work stream, and a social science work stream. Again, these 2, Arianna did, talk to these in our introduction. One of the things that we've realized, again, quite drawing a bit, heavily on the work that we're doing with both the Ebola response in DRC, but also the Ebola preparedness in the preparedness countries, is the need to continuously listen to communities, hear the issues that are out there that then have an impact on their behaviors. One of the things that we did find out is that a lot of times the barriers, the things that stand in the way of people adhering to whatever recommended behaviors we're putting across are things that are not even related to social and behavior change. So being able to, collect that piece of information, analyze it, and also pass it on to the relevant colleagues that should be providing, responses to that, becomes a key component of preparedness as well as response. Because if we're not doing that and we just concentrate on messages, then we miss out, a big point, because a lot of times it's not just because people don't have information around the preventive measures or what to do or where to find the services, but it's because of things that are standing in their way, that lead to that. And again, directly linked to that is, the social science piece really that goes beyond to just, understand a few behavioral insights, things beyond just the knowledge, the attitudes, the practices that we typically look into, mostly within emergency context, again, because it's fast, it's rapidly changing. There's a tendency for a lot of us in the field to think that we can just go out and do a quick and dirty, knowledge, attitude, and practice survey, and we're able to run with that. But again, we've seen that there's so many things that, stand in between people intending to do something and they actually doing it. That we need to be able to borrow the expertise of social scientists, anthropologists, to go out there and understand, get some deeper community insights to be able to inform, in the interventions that we were intending to put across. Linking this to, again, a typical example. One of the key messages, this is not COVID specific, but Ebola specific. In South Sudan, about a year and a half ago, we were looking at, there were messages that are being put out about communities avoiding consumption of bushmeat, which is a common practice within these communities. But when we deployed some social scientists to get some insights in there, we did realize that, you can't just be passing out a message about consumption of bushmeat, but rather you need to be talking about how to make bushmeat trade safe, and look at the entire supply chain, from the hunters to the marketers to the people who slaughter to those who distribute to the restaurants that cook, so that when you're addressing that, you address the entire spectrum along the, the supply chain of that. So, I know I'm running out of time, and again, I'm available and we'll be having, some conversations to build on that, but that's just a quick thought that I wanted to share. Aspects of coordination, aspects of community feedback, aspects of social science, really being key elements that we need to make sure that they're in place as we, prepare for, as well as respond to, public health or other emergencies. I'll stop here for now. Thank you.
Thank you so much, Charles. A really great framing to kick us off. So now we'll move on to Renu. And Renu, if you can share and reflect on some experiences shifting to RCCE activities from ongoing food and nutrition security programming and some of the lessons learned on that front.
Thank you, Arianna. I currently work with USAID's Global Social and Behavior Change program called Breakthrough Action, which is one of several health and food security projects under the Rise to Umbrella program in 2 West African countries, Burkina Faso and Niger. Actually, Breakthrough Action is a global program, but I work in Burkina Faso and Niger. In this context, Breakthrough Action is primarily a capacity strengthening program that works with the resilient food security agencies, health service delivery projects, and the respective ministries of health to improve knowledge and capacity to design, deliver social and behavior change programs. So we do not implement widely. We work with the RIFSAs to help them implement more effectively. So in the COVID context, Breakthrough Action pivoted in 3 different ways. In Burkina Faso, we worked with the Ministry of Health on risk communication and community engagement subgroups at the national level to help create or strengthen RCCE systems. Then as a project, we, like most other projects, had to restructure our programming to function in a remote environment. That meant we had to change these types of activities. We had to develop distance learning approaches to deliver our planned content. We had to adapt pre-testing of communication materials using WhatsApp, since we were not able to travel, or even in the country, our team was not able to travel to test things. And we developed mobile phone applications to train community health workers about COVID-19. And the types of lessons we learned from these pivots were that participants often had difficulty with learning new electronic platforms. We used Google Classroom that most people were unfamiliar with, and it took time to bring these groups up to speed. It takes longer to deliver the content and to make sure that people understand. Just as I think schools and the educational system discovered, it took almost 1.5 times longer to deliver the exact same content. And then we tried using mobile telephones to deliver content, which was innovative, but there were several challenges that we discovered. One is that the mobile phones, the phone numbers that we received from the Ministry of Health were not always valid. Community health workers didn't recognize the numbers, so they didn't pick up. The system only used one mobile phone company, and many of the community health workers did not have a phone within that network. And there wasn't enough coordination with the Ministry of Health to ensure that the program communicated to the community health workers well. Then there were some other ways that our program and other RIFSAs in the region pivoted. And that was by using existing systems to deliver COVID-19 content in the community context. We adapted community engagement activities to the COVID context by following the government guidelines, such as limiting numbers of people at events, maintaining social or physical distancing, enforcing mask wearing, and providing hand washing stations or hand sanitizers at all events. We leveraged community structures to adapt to the constantly changing context. Mother leaders provided COVID prevention messages. Water user committees installed hand washing stations made from locally available materials, and they shared prevention messages related to hand washing. And we learned a range of different important things from these experiences. For programs working in unstable environments, where they were already considering and thinking about some of these things, it was very easy to pivot. There are systems that already were in place to support remote engagement, such as remote monitoring and using phone systems to monitor and make sure things were continuing to happen. And communities are amenable to providing messages to their stakeholders, and it was easy to leverage these systems. But I think some of the most important things was having existing relationships that did not require building trust during this uncertain time. And this was absolutely critical. But it was also important to continue maintaining awareness and knowledge throughout the pandemic. Linked to this issue of trust was the need to respond truthfully and to address underlying factors of fear, anxiety, and stigma openly. These feelings were real and they had to be discussed. By pretending they didn't exist, it would have created more insecurity and anxiety among our beneficiaries and program staff. And finally, the project recognized that resources and information channels vary by demographic. And it always is important, but it was particularly important in this context to tailor communication to participant groups to ensure that the messages were acceptable, they were accessible, and they could be accessed by those who needed them. Thank you.
Thank you so much, Renu. Really, the lessons in practice reflect, I think, very much what we've learned through previous efforts, and just really reinforces those key principles. So moving from here, we'll hear from Nicole about her experience implementing RCCE and using methodologies from previous SBC programming and shifting that into RCCE initiatives and some of the interesting lessons learned on that front. So over to you, Nicole.
Thanks, Arianna. Can you hear me okay?
Yes, we can.
Okay, great. So just for a little bit of background information, my name is Nicole Grable, and I'm on the COVID Technical Response Unit at Mercy Corps, and my focus is social and behavior change and public health. And so I am just going to share a little bit of our experience from our work in Haiti. And this was done in March. And it was really focused on our community leader and user-centered RCCE strategy development. This work overlaid our BHA and food security work in Port-au-Prince. So while the BHA program was focused on food security, the COVID-19 program was helping communities to have up-to-date and localized information in response to keeping them safe. The process and framework is rooted in our overall Mercy Corps community engagement and participatory planning approaches, and there were added layers in from a health lens and a contextual lens around specifically RCCE. And I had used a similar approach in other programming related to HIV and service delivery and a variety of other programs, and so was eager to adapt some of the additional principles related to health here. So you can see that we used a human-centered design approach. It was very interactive and fun, and the community leaders enjoyed it. Next slide, please. We went through a very systematic process. It was rooted in an assessment that was conducted. We used the WHO and IFRC collective service assessment questions and adapted them to our context. So those were specific to RCCE. So if you haven't seen that resource, it's a great one, and I'm happy to share it with Arianna, and perhaps she can share it in an email after. When we did the assessment, once we got those findings back, or alongside doing them, actually, we did a stakeholder mapping exercise to understand who was doing what in the area with the different partners. You can see it's on a whiteboard there. It wasn't the most sophisticated stakeholder mapping, but we wanted to at least get a lay of the land. We then continued to proceed with testing the materials and doing training of trainers for my colleagues that were in Haiti to be sure that they had the facilitation skills in order to facilitate the human-centered design. Initially, the materials had been created in English. They translated a lot of them to French, and then were simultaneously translating them into Creole during the facilitation exercises. So that then went into additional ongoing support to the communities once we knew what they needed. Next slide, please. So the project was conducted in Cana, which is an area near in Port-au-Prince, and Cap Haitian. The assessment was with 220 community leaders with a distribution that you see there in the percentages, but we talked about community perceptions, behaviors, information that people needed, misinformation and rumors, and then of course had questions about vaccines and vaccine confidence. Some of the things that I think are really important to remember and lessons learned always, especially if people are new to human-centered design activities, is that it's a unique process, and it's important to, as my colleagues mentioned to me, release expectations of how you think it's going to go, and embrace the learning journey and the experience of adapting to different contexts. It's really important to do the preparation even for the facilitation of human-centered design, because there are additional nuances in facilitation that are important, especially around preparation and making sure you have the materials that you need, and ensuring that your audience knows what you're asking of them. And then, of course, to support governance best practices. That was an important piece of engaging with the community leaders as we went through the RCCE creation with the HCD, human-centered design lens. So they were involved in the process from start to finish. It was a co-creation and very engaging process. Next slide, please. The design process, we first shared back the assessment data. We wanted to share back what we had heard from them initially. Really important piece here was to set goals. We had the community leaders set first individual goals for what they wanted to see. We had them grouped by community leader type. And then after they initially set their individual goals, they set then group goals as a collective force of community leaders, if they were youth leaders or women's group leaders or entrepreneurs or farmers, religious leaders. We had them set different goals depending on who their audience was. We did some of the traditional human-centered design activities like empathy mapping and journey mapping. The journey map was specific to what their experience would be reaching the goal that they set. So if their team set a goal as a group, that was at the end of their journey. That was their goal for their community. And so the journey was about their experience, not necessarily about the specific behaviors that the communities were adopting or not, but it was about their behavioral experience in reaching their goal as a community leader. The framework that you see on the bottom left that's our RCCE framework. On the left-hand side are the questions that we asked. Along the top is based on by community leader type. So each group completed the RCCE strategy as a collective team. We then took them through a messaging workshop so that they could create their own content based on key messages that were created by our team. They then adapted them based contextually on what they would say to address the questions and concerns in their community. Next slide, please. This is the RCCE framework, as you see here. So we had them think about, as their own community, as a leader within their community, who is their target audience? Not the big picture target audience that they're hearing in the news or that people believe should be the main focus, but who did they feel like after everything that they had learned in the training? We did trainings about COVID, about misinformation, about vaccines. We wanted them to think specifically about their community. Who were the vulnerable populations and what are those key behaviors they were looking towards? What will they say in the activities they will do? And we worked through this whole thing with them. Next slide. And this is the process. So this was a very specific process too, and a big lesson learned along the way. I think I'm infusing my lessons learned as I continue to go, but a big lesson here was to map things out slowly. So layer these pieces in to for the first question. So you can't put the whole framework up on the wall at once because that can be overwhelming. So we really helped them target the flow with, first we asked the first question, who is your target audience within your community? And then who are the other vulnerable populations, and so on and so forth. So it slowly built one on the other. Next slide. And then we did the content message and role play development. Next slide. I think that's everything I have. I think I infused my lessons learned along the way, but I think it was just really important for people to have practiced the human-centered design process. It is a process in itself, and to take the time to layer in the activities. Over to you, Arianna. Thank you.
Thank you so much, Nicole. Very, very interesting and very good example of really applying a community-centered and led approach in practice. So thank you all three panelists. We are perfectly on time and have just about 10 minutes to address any questions. I see that there are a few in the Q&A already, so perhaps we can start with those. And the first one for Nicole around the empathy map, and if you could share a little more detail on that.
Sorry, I didn't hear the question.
So the question is, can you share a little more in the empathy map?
Oh, sure. So the empathy map was where the community leaders thought about themselves as the community in which they're serving. So what the key principles of an empathy map is, you help them think about what would the people in your community do, say, think, and feel related to the objective that you would like them to reach. And another lesson from past history experience in this is to have them do the what would you do, because that's a very concrete piece. Empathy mapping and journey mapping is very abstract. And while it can bring out a lot of creative ideas and insights, it's hard for people to think in that way. So I oftentimes put examples up in the presentation and I give people examples. So what would someone do? What is the verb? What is the action? Do they walk? Do they talk? Who do they talk to? What are the actual actions if they're moving their body? If they're doing something, what do they do? And then what do they say? And so when I do the what do you say, I have them stand up and do a role play and act like they run into someone walking down the street and someone asks them a question. And what would that question be? What's the question that comes at you? And then what are the words that come out of your mouth? So I have it be very interactive so it's tangible and less abstract. The lesson in that is to go from the least abstract to the most abstract. So do, say, think, and then feel. And that brings out additional insights, and you can prioritize those when you go through the journey mapping exercise. Hopefully that helped, Arianna.
Excellent. Yes, thank you. I think just to maybe round off the HCD piece, there's a question around providing a link to operational guides for human-centered design and how one can get skilled on the human-centered design process.
That question to me, Arianna? Okay.
Yes.
So there are a lot of different resources that are out there. The Stanford's School of D, I think is what it's called. They have a lot of resources online, but there are also a lot of training materials, certificates that you can do. There are a lot of also programming resources, I think, that are available online. I actually learned a lot of human-centered design from meetup groups where I would join workshops and just go join the sessions. I've since completed certificates and things of that sort, but I would recommend if you find meetup groups where they're doing tangible, actionable, process-oriented, where you can really I don't know how much they're doing them in person right now, but you can still learn how to do them abstractly on Miro board, online, and I still use those tools even now doing human-centered design. But I can probably share some resources around and maybe they can get circulated afterward.
Thank you, Nicole. There's another question here. I think it's an excellent one. For Charles and Renu, and it's what would you do differently in the next public health emergency response? So Charles, you want to take that one first?
Thanks. Yes. Let me make an attempt. So there's a couple of things that we've always talked about. Within the organization, within the organization that I work, but also within and among the partners that we work with, but even with the host governments that we work with as well. And this is linked to the need to invest a lot more in preparedness. There's been a lot of lots of things have been written about the need to prepare for the next outbreak or the next emergency or the next disease X. And there's various parameters for that we'll be looking into, whether it's preparedness in terms of resources, preparedness in terms of human resources and capacity, preparedness in terms of building community resilience, making sure that the communities have some basic information, basic knowledge, basic skills to be able to act as fast responders, because they indeed are. So what could be done differently in the next emergency response? I think even before I talk about the response, is they have quite some investment in preparedness, which would then make the next public health emergency response even a lot easier, because with a lot of the basic things would have been put in place that then the response would build onto.
Thank you, Charles. I think that lines up very nicely with actually Renu's experience as well, in terms of having those existing relationships with communities and having the trust already established in order to quickly and successfully pivot into a response effort. And Renu, on your end, what would you do differently?
I think in an emergency kind of situation or an unknown situation, you sort of go head first, feet first into what you're doing, and you really, as much as you can plan ahead of time. I think we learned a lot of lessons with digital kinds of technologies. They're possible, but you can't do it perfectly the first time. So you need a lot more planning. And, I would echo Charles's idea about preparedness, to do things differently, and really to not expect that it's going to take the same amount of time. We saw it took at least 1.5 times longer to do everything we wanted to when we were pivoting to digital activities. And then using the resources that you have. I guess that's not doing something differently, but it's something really critical, I think, is to, maybe groups or different types of people are much more capable than we often give them credit for. I know in the session I was in earlier today, some of the participants were talking about how flexibility and accessing communities on the ground to do the work that maybe community health volunteers did previously. You can get families to do things. It just takes a little bit of time.
Thank you so much, Renu, and all. I see another question in the chat. Unfortunately, I know that we need to close the link at 9 on the dot. So hopefully Ancha's question, thank you, Ancha, can be answered perhaps offline. But thanks so much for all this really great insight from the panelists. And there are a few other sessions on RCCE throughout the event. So please, if you're interested in learning more, there's a collaborative session tomorrow. You can see that in the schedule, as well as another session specifically on radio shows and messaging during the pandemic in Ethiopia. And I'd like to ask panelists to please fill out the evaluation that was sent in the chat box. And again, thank you all so much. Chris, any last words?
No, I think that was it. Thank you everyone for attending. We really appreciate you coming here and asking questions.